Thanks everyone who is so timely so far. Just wanted to give it just a few more minutes to allow folks to log on. Want to be mindful that Dr. Berman has to log off around 8:50 today, so maybe we'll get started at 8:03. All right. Well, thank you all for being here this morning for our grand rounds. I have the great honor of being able to introduce our speaker today, Dr. Jeremy Berman, who I was able to be connected through a mutual colleague at Landmark Health. Um, Dr. Berman is the Senior Medical Officer for Quality and Education at Landmark Health, and will be explaining more about their model of care. I was so excited to have him speak to us today. For those of you who maybe work in the primary care space, you may have overlapped with them, but they've been a real leader in the industry, being around for the last 10 years to really provide in-home care for our most sick and complex patients. So I'll turn it over to you, Dr. Berman.
All right. Thank you so much, Dr. Wang. And y'all can hear me okay? Okay. And you see my screen in presentation mode? Okay. Yeah, thank you for the introduction. And yeah, thank you so much for inviting me here. It's definitely exciting for me to get out of the kind of Landmark orbit and come and visit with all of you today. So as Dr. Wang mentioned, my name is Jeremy Berman, and I'm with Landmark. I'm the Senior Medical Officer of Quality and Education, physician, trained in emergency medicine, went to University of Washington for undergrad from Seattle, been in Seattle most of my life except for med school and residency. So happy to be back at UW, I guess virtually. I've been with Landmark coming up on 7 years, and you know, Landmark, as Dr. Wang mentioned, has actually been around a little less than 10 years, I think about 8 years. And so I've been with Landmark from nearly the beginning, and seen a lot of the evolution and the change, and so at this point been working kind of in the home-based space for a while now. And my roles have changed as I've been at Landmark. I was initially serving in the medical director role for the Pacific Northwest, and oversaw kind of our clinical and our operations for our Washington and Oregon states, and all the providers that were caring for patients in those states. And about a year and a half ago, moved into this role where I oversee kind of the whole clinical quality improvements, our provider education platform. But I wanted to come today and just talk about a little bit about Landmark model. I also want to just kind of show. I also want to talk through some of the challenges of home-based medical care. I think there's a lot of activity in the home, delivering care in the home, not just nursing care, but provider care, bringing physicians back to the home. And there's a lot of activity in the space, and there's a lot of private businesses that are getting into the space, a lot of health systems and primary care groups that are getting into the space, whether it's primary care in the home or hospital at home. The challenges of both of those are the same or similar, because operating in the home at scale can be very difficult and requires the right operational and the right clinical, the right business model to make it sustainable. So I want to discuss some of that, and also just some of the innovations that's happening in the space, because it's a lot. And if you're keeping track, if you're reading the publications coming out, there's a lot of activity in the space. Landmark was an early entrant and has been a leader for a long time, but there's been a lot of provider groups that have sprung up, over the last few years. And as you may have seen by the title slide, as well as the lower part of this slide, Landmark got acquired by Optum about a year and a half ago, and so there, a lot of changes have been happening at Landmark since Landmark was acquired. A lot of growth, and we've come together with another home-based medical group called Prospero. So lots of interesting changes. There's a tremendous amount of scaling that's happening kind of nationally within the Landmark model since we've come under Optum. But what is Landmark? Landmark is really, as Dr. Wang mentioned, the national leader in home-based medical care for complex and frail seniors. So Landmark is a program that is geared for polychronic, frail, geriatric patients. We provide primary care in the home. We provide urgent care for patients, 24/7 availability of in-person, in-home urgent care. We have a palliative care team, as well as what we call a palliative pathway program, which I'll talk a little bit more about. And we also have a behavioral care model and employ the collaborative care model that came out of UW. And we have a lot of interdisciplinary support across our team that are helping patients. And the frequency and the cadence of that interdisciplinary support is really dependent on the complexity of the patient. I think one thing that's important to note about Landmark is it is a what we call a risk-bearing entity. It is a value-based care organization. So the way we approach patients, it's not through the fee-for-service lens. So we're not billing the health insurance per visit. We're not submitting bills to the patients or co-pays. The program is free for the patients. We partner directly, usually with the health plan, on the business relationship, and have typically a shared savings type of model. And if there are questions about that at the end, I'm happy to answer them. So it's intensive. It's an intensive program. When Landmark patients become eligible, for Landmark, they get a lot of services. They get a lot of touches in the home. They get a lot of touches telephonically, not just by our physicians and our advanced practice providers, but by our nurses and our social workers and our non-clinical health navigators. A lot of support. It's very intensive. Of course, patients can say they don't want as many touches, but we believe that the clinical model we've built over the years and improved upon over the years is the right model for this sort of slice of the population. And we're talking about patients who on average have 8 chronic conditions. To be eligible for Landmark, you have to have at least 6 chronic conditions, and we'll get more into the eligibility. But we do focus on the polychronic and the frail. Our average age of patients at Landmark is 81. Patients are all living in the home environment. They could be living in assisted living, but many of our patients still live at home. A lot of them are homebound. About 70% of them have a lot of difficulty getting out of the home and getting to to see their physicians in the community, whether that's their primary care physicians or their specialists. And another important thing to note is Landmark does not take on, we are not the primary care physician within that patient's ecosystem. They still see a primary care provider. They still see their specialists. We really come in and augment the care that the primary care is delivering, as well as the specialists. When Landmark was started, really the home was the place that the leaders of Landmark felt that the care needed to be delivered. The home for these particular type of patients, because they're having difficulty getting out of the home, because brick and mortar primary care is typically open Monday through Friday. Business hours, these patients needed more services. They needed more availability. 70% of our patients are functionally dependent. So we go and we find these patients. We know where they live. We do have some patients who have housing instability, and we see patients in the homeless shelters. We'll see them on the streets. We'll see them wherever they are, and we will go and find them because our model, and I'll talk a little more about how we approach kind of the population health and the panel management, but we are really trying to see these patients at the right cadence, and patients are different within our bell curve of patients' complexity. We have patients that are extremely frail, and we're seeing those patients maybe twice a month, once a week, whatever they need. And there are other patients who are eligible for Landmark and receiving care from us, and by definition, they're quite sick, but they're more stable, and we might see them 2 to 3 times a year. Our nurses will check in with them a few times a year. So we really we have a flexible model that provides high touch support based on the need of the patient. Patients get around 6 to 8 in-person visits with the provider per year on average across the whole population. And when you look across all of our visit types, we have a lot of different encounter types, visit types. When we go and see the patient, 50% of our visit types are the behavioral, palliative, or urgent in nature. So patients are calling us a lot for urgent visits. Our providers are equipped, all of our providers are equipped with a tackle box and a trunk full of medical supplies. So we can go in the home, our physicians and our NPs can go in the home, we can draw labs, we can give IV fluids. We have a tackle box of medications that no scheduled medications, but we have some IV medications, we have some antibiotics, we have Lasix, some antiemetics. So we're able to really try to treat patients where they live and whenever they need it. In terms of our clinical model, as I mentioned, we have these pillars of our clinical model, and I'll get into a little bit of each one of these. And so our longitudinal care model, as I mentioned, it really is a population health model. We risk stratify patients based on their complexity, and we use a lot of data that we get from our data team, from health plans, from CMS, to drive a score, maybe similar to what you've all seen in your EMR. But we really we leverage this acuity score to help drive the type of care that patients are receiving. So patients, are getting in-home visits by providers based on their acuity level. Also based on their acuity level, they might get complex case management by the nurses. We do a lot of work around transitions of care. So around 80% of our patients who are admitted to the hospital and discharged back home, we're seeing around 80% of them in the home by a provider within 3 days. That's a really important part of our program. And we don't just see them once, we see them on that 3rd day, and we see them again a few days later if they need it, and 2 weeks later. I'm just making sure that they've got all their follow-up appointments scheduled, they got the right medications, they were discharged home with the right DME. Our patient population, kind of pre-Landmark, their readmission rates are somewhere between 40 to 50%. So very high rates of readmission, especially for certain diagnoses. So we really focus on patients who are coming home with CHF, coming home with COPD exacerbations, coming home with orders for home health, DME. We know these patients are extremely high risk, so we put all of our resources really towards those patients in the transition of care period. We have a lot of people at Landmark working on behavioral health and social determinants. Both are we have employed psychiatrists as well as psychiatric nurse practitioners who are working very closely with our social workers, our LCISWs. And we have a position that we call an ambassador role, which is an in-person, in-home, non-clinical health navigator who are helping fill out forms, helping get Meals on Wheels, doing kind of what we call social work light activities so that we can really elevate our social workers to be very, very much involved with the collaborative care model. On the urgent care side, as I mentioned, we have 24/7 availability. Part of what we're doing when we're seeing patients for longitudinal care is educating them that they will experience an exacerbation of their chronic illness. That will happen to them at some point relatively soon. So educating them on early symptom recognition. We're available all the time. So we encourage them to call us to come if they need us on a Saturday morning, on a Sunday night, on Christmas Eve. And if they're not aware of what are the early symptoms of their exacerbations, then they're not going to remember to call us, and they're going to end up going to an ER and all the challenges as an ER doc. I know them very well. So we put patients through what we call our urgent episode of care, which rather than thinking about an urgent visit as a one-time visit for a UTI or for a cough, we know that these are very frail patients who decompensate quickly. And so we put them through our episode of care, which means we see them for an urgent visit today. And based on the chief complaint, based on the diagnosis, we will see them again either 2 days later, 4 days later. We'll have a nursing call, check in with them the next day. We put them through a sequence of high touches and high visits until they're back to their baseline or what we think is their new baseline. So we think the urgent episode of care model is an important way to kind of have an end-to-end platform around treating urgent visits all the way through. Palliative pathway. I know there's a lot of palliative folks on the call. We have a program at Landmark where we identify patients who, based on the data and science team's analytics, that these are patients that have less than 12 months to live. They get a palliative visit with our co-visit with our providers and our social workers, and really focus on end-of-life goals, serious illness conversations, coordinate with PCP, and determine what are the patient's goals. And because the eligibility of Landmark patients are so sick coming into the program, there are many patients that are hospice eligible at the time of enrollment in Landmark. We have a mortality rate annually of our population around 15 to 20%. So these are patients that really need serious illness conversations, advanced care planning, and many of them haven't had that by the time we reach them, which is, of course, surprising, but also indicative of how difficult it can be to have those conversations in a 15 to 20 minute visit in the clinic. So we really prioritize that, focus on that. We have a lot of workflows around hospice initiation. We work closely with a lot of hospice agencies around the country to ensure that there's timely admission to hospice. So a lot of work done around end of life, serious illness conversations, training around that for our providers, make sure everyone is competent around palliative. I'll keep going, but I'm going to save time for questions, and feel free to interrupt me at any point. This is what our care team looks like, physician-led. We do hire advanced practice providers, typically one physician to 2 to 3 APPs. They work together within a pod. We call a pod a geographic pod. And the pod is supported by other disciplines. So social workers, behavioral health providers we have a role called an urgentivist, which is a provider is just specifically focused on doing urgent visits. A lot of ER trained physicians, people who've been in the acute care world, they're the ones who are mobilizing into the homes, when needed based on patients' needs. All the patients are supported by nurses. Nurses are one of the few positions that are not in the home. They're telephonic based, and they do a lot of care coordination as part of their role. And then we have pharmacists and dietitians in every one of our markets. So a lot of our pharmacists are working with our providers and our patients and the PCPs in the community on deprescribing, and working with the social worker when we identify med adherence challenges. If it's a medication cost issue, we work with the patient on finding an alternative. Dietitians as well, obviously very important role and highly utilized in our care model. Typically, how do patients qualify for Landmark? So typically Landmark contracts with any entity that holds the risk of the population, or the financial risk of the population. So typically that's a health plan, a Medicare Advantage plan, who's taking care of Medicare patients. We also do partner with some Medicaid plans, and we have a lot of dually eligible Medicaid, Medicare patients as well. We have, I think, around 15 different health plan contracts across the country, and we have grown a lot over the last 7 years. When I started, there were not that many patients who were eligible for Landmark, and now we're up to, I think, 150,000 patients across the country that are eligible for Landmark. Doesn't mean all of them have signed up and have enrolled. We have around 50 to 60% of eligible patients who are receiving active care for Landmark. By the end of this year, I think we're going to be in 40 states around the country. Obviously, with Optum's acquisition and support, they have a lot of interest in scaling us, to as many patients as possible. So we contract with the health plans. It can be a health system as well, and we do have contracts with certain health systems across the country to really manage, take care of, provide support to their sickest patients. It's generally around a 5 to 8% of a Medicare population would be eligible for Landmark. That's just the kind of sliver of population that becomes eligible. Patients are identified through the partner, or the health plan or the health system. The patients are identified through their data based on number of chronic condition points, and I'll get into that in the next slide. And we try to engage every patient, meaning we try to get every patient who's eligible, at least make them aware that this program exists for them, that they can have this resource in the home, support them. We don't get to 100%, of course, engagement of patients signing up. There are a lot of patients who think this is just too good to be true. How can this be possible? You're sending a physician to my home for free. So there's a lot of skepticism, of course, because this is a population that gets a lot of phone calls and a lot of scams. But we work closely with the primary care community and the specialists to have them advocate for this program. For many patients, Landmark is really a lifeline for not just the patients, but for the family members, for the caregivers, in being able to help manage some of their conditions, help them stay at home as long as the patient wants to, as long as it's safe, help with transitions of care and everything else. This is a look at it's a little outdated, but this is an example of how patients become eligible. So we have a health plan contract. We partner with a health plan. In Washington State, we have a health plan contract with Humana and with Community Health Plan of Washington. We have a national health plan we have national contracts with multiple, many of the big payers. And then we have a lot of contracts like with Community Health Plan of Washington across the country with smaller local health plans. So we form a contract with the health plan, and we provide them with our eligibility list. So each one of these conditions that you see on this list, and this is not comprehensive of the conditions, but each one of these conditions carries a different point value. Higher number of points for conditions that are more difficult to manage, that result in higher utilization, higher hospitalizations, more medications. So atrial fibrillation, COPD, CHF, CKD, these are 1-point conditions, but a pressure ulcer with necrosis, stage 4 ulcer is going to be 4 points. End-stage renal disease on dialysis is an automatic qualifier for a landmark. That's 6 points automatically. So the way that landmark has structured the eligibility criteria is really based on durable utilization, rather than looking back and saying, let's just take care of patients who utilize the hospital a lot or who have been to the ER a number of times. We know that choosing that type of population, there's often regression to the mean. Those patients end up getting healthier. And Landmark is a program that is really geared for people who are sick, and it's not that effective for healthy people. It's an unnecessary program for patients who are doing very well at home. And so Landmark's trying to choose the sickest population that is going to sort of, remain sick based on their chronic conditions, not expected to sort of turn around and go out and play golf, every day in a few months. So this is the eligibility criteria. And then they have to live in a service area in which we operate. So within Washington, we are, I moved out of the market, but, we've traditionally been in Snohomish, King, Pierce, Thurston, Spokane counties, Clark County down at the border of Oregon, and a few counties across Oregon. That's growing. Our service area is growing, but if patients live in Yakima, they're not going to have eligibility to Landmark, even if they have a community health plan or Humana and they have enough conditions.
Dr. Berman,
Yeah.
there was a question in the chat.
Yeah.
Would you prefer to say that to the end, or
No, I can do it. Yeah. What is CHA and Optum is? Oh, yeah. So CHA is a community health advocate, and they are a non-clinical role that will bounce around to different primary care groups and clinics, and will meet with the nursing team or the administrative team to share eligibility files. So which are the shared patients within that clinic, how many Landmark patients are eligible, which are the patients who are actively engaged and enrolled in Landmark, which ones aren't. Because often for us to get to the non-engaged or non-signed up patients, it does require the support of primary care. Once primary care says, oh yeah, you sign up for this is great service, patients will sign up. So is Optum still a subsidiary of HCA? Optum is a subsidiary of United Health Group. Tell us about corporate structure in your experience. Who do you report to and how's that go? Challenges of overseeing nomads in the field. Yeah, great questions. Dr. Ong, these are all fully employed physicians. We really haven't had contracted physicians, very one-off. We actually had some fellows, geriatric fellows who moonlighted at Landmark for like after hours urgent care, but yeah, everyone's fully employed. Yeah.
Oh, sorry. This is Ton. And so for the other team members, other than the physicians, such as the team-based care that you have there, the pharmacist and the dietitian and the ambassador and the CHA, for example, are those also employees?
Yeah, everybody is fully employed. We just don't have anyone. I mean, I'm sure there are some contracted people, in some fashion or form, but not on the clinical team.
Okay.
All these folks you see here are all fully employed. And then, of course, we have our medical directors and our regional medical officers and our chief clinical officers and our chief medical officer that provide sort of oversight, structural support to these markets or care teams or regions. I think to answer Dr. McCormick's question. Yeah, I mean, I think that I came into Landmark when it was a baby and it was a startup, and people were just, we were all just running around seeing patients. And I think it's changed a lot over the last 7 years, and I think that there are some things that are really nice to be part of, like a massive entity such as Optum. There's a lot of great resources, a lot of educational resources. There's a lot of smart people who know what they're doing, who have been thinking about some of these challenges in operating a home-based model for a long time, even though, and they have home-based models at Optum before Landmark, but Landmark, nothing like Landmark. But yeah, I think there's also challenges with just trying to keep up with the scale of what Optum has set forth. That's very difficult. It's difficult I oversee quality. It's difficult to, I lose sleep over how do we maintain quality when we're hiring so many people who aren't familiar with the home-based environment, maybe aren't familiar with the geriatric population. I mean, we have close to 1,500 providers at this point, and we're going to be hiring a lot more over the next year. So I think trying to maintain the quality is going to be one of Landmark's biggest challenges. I report directly to the chief medical officer, Chris Smith, who's been doing home-based medical care for over 20 years, came out of Mount Sinai and was at Northwell running their home-based program for a long time. And he's a great leader in the space. And I respect him, tremendously. Came from an academic environment. How do we know if our primary care patients enroll active? Yeah, Carrie, that's a good question, and it would it'd be one of the CHAs that would outreach. I can follow up. Since I'm not in the market anymore, I'm not as close to what's happening within Washington, but typically when a patient is enrolled in Landmark, PCPs are getting phone calls, they're getting after visit summaries from the Landmark care team. There's coordination happening between the PCP and the Landmark provider. Do you know the demographics of non-English? I don't know off the top of my head what I think, the demographic, because of the way that the eligibility criteria works, it's not based on anything but chronic condition and where the patient lives. So it's typically representative of the community where the program is. And so we have a lot of patients in Southern California, who speak Spanish, or different Asian dialects. So we have interpretive services that is part of our program. We don't travel with interpreters, but we have easy access to interpreters. So sorry, I don't know the exact breakdown of that. Yeah, go ahead.
And then my other question actually is right on this slide, Dr. Berman.
Yeah.
So patients are eligible, and then you talked about how there's an urgent episode of care, because a lot of these qualifying conditions, I don't see them getting better per se, that they always will have these chronic conditions. Right. And so would people be qualified continuously?
Yeah, exactly. It's a great question, because a lot of care management type programs, there is sort of this qualifying period and then they graduate. Landmark patients don't graduate. They get Landmark as long as they want Landmark, and as long as they are with the health plan or with the health system in which there's the contract. So we find that, and this is kind of health planning, but we do find that patients end up having higher sort of retention rates with their health plan when they have Landmark, because they know if they change to Aetna, they're going to lose Landmark. And so they just stay with their health plan because they don't want to lose Landmark. But there's no graduation out of Landmark. And that's exactly why the model was the eligibility model was chosen like this because these conditions don't get better. They do progress. They do get worse. These patients who are our lowest acuity patients are they may be only getting two to three in-person visits per year and a couple nursing calls right now. But we know in 2 to 3 years, they're probably going to need more than that, or they're going to have an event and it's going to hospitalize them and going to set them back. And then we adjust our acuity level, we adjust our cadence of visits, and we, take care of them. And maybe we get them back to where the acuity was before, but realistically, they won't. All right. Curious if primary care, Jared, in this meeting have ever been contacted. I know historically we haven't had a lot of patients with University of Washington for, I don't know why that is. I don't know if it was just the contracts that we had. But feel free to jump in if people have experience with Landmark. I will keep going just because I want to I'll probably just stop in about 5 minutes just to leave more time for questions. But I did want to just speak more generally to the challenges of home-based medical care. So provider burnout's not unique to Landmark. I know it's a challenge across all of healthcare. I think the provider burnout that I'm specifically referring to is a little unique, which is just the challenges of, number one, being in the field all the time. Our providers see about 6 patients per day. So it's not like a 15 to 20 in a clinic, but the 6 visits, each visit's an hour long. Homes can be difficult. Like some homes are really nice, and some homes, there's tons of tobacco smoke or marijuana smoke, or dogs are aggressive, traffic and driving, and not to mention that our patients are just really sick, and a lot of them, I'm sure is similar to your patient population, a lot of them die. And being in the home, I think there's this relationship that you develop with the patient that is a little bit unique. You're with the family, you're looking at their family photos and their artwork on the wall. You're with their loved ones and their pets. And I think there's just this, you develop a relationship with a lot of the environment of that person. And so I think when we lose patients, it is very difficult. We host a 4-hour, every market hosts a 4-hour interdisciplinary team meeting every week, 4 hours. In Washington, it's on Thursdays from 8 to noon. And we always kick off the meeting with patient remembrances. We always have patients that have died over the past week. And one of the ground rules of this part of the meeting is you're not allowed to talk about their medical problems or their health challenges that they had. You can only talk about who they were as a person and what their family was like and what you remember about them. And I think that is really, it's pretty amazing to listen to, because you can just see the relationships that have been developed with these patients. As I'm sure all of you have with your patients, you can just write an obituary about them. And I think being in the home environment is pretty unique in that way. Having an EMR solution, again, not unique to Landmark, but having a EMR solution that's effective in the home-based environment that supports a value-based care program is pretty unique. There are, Athenas and Epics of the world that can support this. Landmark has built their own EMR, which has had some upsides for sure, and a lot of downsides as well. But one thing that it is very good at, and this is our EMR called Ubiquity, is it does allow for in-home scheduling very nicely. It tracks mileage, it routes providers throughout their day to micro-optimize their schedule, to minimize the windshield time. This is the phone app that we have that all our providers carry around. Has the patient's address, uses the mapping function of your phone to get to and from places. It's really kind of a best-in-class scheduling system. There's a lot of challenges with Ubiquity, our EMR, but this is really one of the great features of it. primary care coordination and EMR compatibility is always a challenge. We have our own EMR. We're not an Epic. We try to integrate, and get our messages directly imported into Epic. It's not always possible to do that. Typically, we get read-only access for many of the health systems in the area, so we can see what's going on. But it is difficult to communicate, effectively with busy primary care physicians. Difficult for them to communicate with us being in the field every day. Population health, I think, there are challenges, opportunities and challenges to running a value-based care population health program. You have to have the right data. You have to know what you're doing. You can easily go out of business if you're trying to operate a value-based care provider group without the right support, without the right data and analytics. This is just a typical some of the metrics that we look at when we're talking about effectively managing a panel. I think for time we won't go into that. And I think financial. I think there is a lot of interest in getting into the home-based space, but I think it's very difficult to pull this off like purely through a fee-for-service model. There's just, you can't see enough patients to support all the cost of doing this type of intensive care through normal billing fee-for-service practices. I think you really have to take some risk, financial risk. You have to have some way to create a value-based care arrangement with the partner, because you can't really see more than 5 or 6 patients per day because of traffic and driving times. And we are at Landmark now have a lot of density of patients because we've grown a lot, which is great. Eventually we want to get to a place where providers can even walk to from one patient to the next. But when you're starting out, your density is terrible. I mean, it's 30 to 45 minutes driving between each patient. So there's a lot of inefficiency in the beginning, and that makes it challenging. Yeah, I can stop there, see if there are other questions, and then if there's more time, can jump into the other slides.
Thanks, Jeremy. Wayne here. Talk a little bit about hospital at home. You mentioned that up front, but hit that a little harder.
Sure. I have this slide, just kind of innovations in healthcare or in the home space. I think, as many know, CMS has a waiver for hospital at home that allows hospitals to participate in this program, allows hospitals to admit patients from the medical floor directly to the home. A lot of requirements to support hospital at home. You have to have enough nursing support, enough in-person visits. And interestingly, a lot of the players in the hospital home space are health systems. I think there's around close to 250 hospitals across almost 30 or 40 states that are participating in hospital at home. A lot of them are big health systems. UMass, Brigham, Multicare is participating in it, with their partnership with Dispatch Health. I think it's still early. Landmark has been around, longer than kind of the waiver has, and I think Landmark and some of these other ones on this sort of home-based primary care space have been around longer. So it'll be interesting to see what happens. It obviously is a great option for the patients. I think the question is going to be, is it financially, can you support it long-term financially, and what sort of CMS innovation do you need to continue to make to be able to support it financially long-term, because it is also a very intensive program, and there's some competing business factors with hospitals and emptying their beds into the home, and how that makes sense. Let's see, did I miss any questions in the chat here? Oh, thanks, Dr. Wang, for mentioning that. Yeah, I mean, I think the program, and not just our program, but I think when you look across what's happening in this space in particular, in the home-based space, like I said before, it's really busy. Landmark, Prospero both got acquired by Optum. Concerto Care is also has a presence in Washington State as well as other states, same kind of model as Landmark. Evergreen and Panoramic are provider groups that are specifically focused on chronic kidney disease because of CMMI innovation program supporting CKD for traditional fee-for-service Medicare patients. Dispatch Health, maybe some of you are familiar with, based out of Colorado. They do mostly urgent visits, but they are getting into the hospital at home business and have a partnership with MultiCare. The VA, I think a lot of you have worked through the VA. They have a really great home-based medical care program, and actually Landmark's program, the model that was initially kicked off back in 2014 was really based on the VA program. Ripple is a new company that got launched a few months ago. It'll be interesting see what happens with them, but based out of Seattle, started by the guy who used to run Aegis, Chris Angskoff, and it's really focused on dementia patients. And they want to go sort of, all of these companies are all value-based. They want to take the financial risk. None of these want to be in the fee-for-service environment. So maybe they have to start in fee-for-service, but the goal for all of these is to eventually get to a point where they're owning the financial risk of the population. Any questions? I'm going to have to jump in just a few minutes, but wanted to just leave some additional time for questions.
Dr. Berman, there are a few of us on the call who also work in the post-acute care space.
Yeah.
We will participate in those transitions or care coordination as well.
Mm-hmm. Yeah. So, and when you say the post-acute, like you're working as an attending in a SNF?
Yes. Mm-hmm.
Yeah. Okay. Yeah, so we do, our transition of care program does include the patients who are discharged from the SNF to the home. We have great processes at Landmark for knowing when a patient goes home from the hospital. We have a lot of tight coordination between hospitals and our care managers. It becomes a little trickier when patients are in a SNF, and because there are many of them, and patients are widely sort of distributed throughout them, and communication with some of the SNFs can be a little challenging. We're not seeing patients while they're in a SNF. We're seeing them the moment they kind of touch home. But yeah, a lot of we try to have a lot of coordination with the SNF and the SNF providers, but obviously, it's difficult. SNF attendings are in and out and have other jobs, and it can be hard. All right. Well, I guess just to round it out, home-based medical care, I mean, it's not going anywhere. This space is growing. I think can be very effective and helpful for certain patients, certain population. It has to be the right clinical operating and business model to be sustainable, not just financially, but just also for the providers. And I think we're going to continue to see a lot of innovation in the industry, both coming from private equity, venture capitalism, CMS, and also from health systems participating in the hospital at home program. So I think it's a very interesting time to be watching the home-based space. So thank you very much. Dr. Wang has my email. If anyone has any questions, follow up, please don't hesitate to reach out. And I was asked to display this for all of you. All right, and I am going to, I'm going to jump off, but thank you very much. Thanks, Dr. Wang, for the invite.
Thank you so much for being with us this morning.
Okay, bye-bye.
Bye-bye.